All right. Well, welcome everyone. Thank you so much for everyone who is attending today's webinar on conversations that matter, research insights on end-of-life care for women veterans. Today, I am joined by Dr. Quinn Galloway Salazar and Dr. Brandon Verlick. My name is Emily Marge, and I'm with the We Honor Veterans Program as a Veteran Services Specialist, joined with my Supervisor and Director of Veteran Services at We Honor Veterans, Catherine Kemp. We are very, very excited to be hosting this webinar, to be sharing new resources from the VA, and have this conversation, everyone, on women and end-of-life care. So before we get started, just some housekeeping rules. This webinar will be recorded, available on our website in our resource library the next couple of days. So thank you very much. We will also be having this webinar PowerPoints available at the end of the webinar, and it will be recorded on our website, not only in our resource library, but on our new Women Veterans webpage that will be shared in the chat box. So without further ado, I would love to introduce you to Dr. Quinn Galloway Salazar, who will be getting us started on conversations that matter. She is a U.S. Army veteran and founder of In Their Honor, and an end-of-life doula who enjoys helping her fellow veterans at the end of life. Please take it away.
Well, good afternoon, good morning, wherever you are in this nation. We welcome you to this workshop. As Emily noted, my name is Quinn. You can call me Quinn from now on. If we see each other in the same spaces, you don't have to call me Dr. Galloway Salazar. I am your peer. I am your colleague. Please call me Quinn. Next slide. So it's such an honor to be here to talk about a topic that is so near and dear to my heart. As a woman veteran, I truly understand some of our unique experiences and our challenges that we face following our service. But before we get kicked off today, I want to talk a bit and take a moment to honor the memory of someone so dear to my heart, my friend, Dr. Kate Hendricks Thomas. Kate was not just a colleague, she was a friend. She was a Marine, she was a family member, she was a mom, a wife, a daughter, a sister, so much to so many that loved her. For all of us who had the opportunity to have a piece of Kate, she was a beacon of light and inspiration to all who had a privilege of knowing her. She embodied the unwavering spirit and dedication that defines our women veterans. I remember the passion with which Kate spoke about her research as it related to women veterans being invisible. I recall the fire in her eyes as she advocated for the voices of women veterans to be heard. Her tireless efforts continue to inspire so many of us, guiding us in the mission to honor her legacy at every opportunity. About a month before Kate passed away, I had the opportunity to spend some time with her. And one thing that Kate shared with me and challenged me to do was to continue to tell our stories. Really, really big challenge, I have to say, but one that I was so honored to say yes to. So I thank you all for joining us today, not only as we honor Kate, but as we also honor the legacy of all women veterans and embark on this journey together. Next slide. A little bit about the state of affairs and where we sit within the women veteran population. More than 2 million women have selflessly served our nation. And I'm sure that many of you all know that on June 12th, and I'm going to say it again for those who may not know, on June 12th, as a nation, we are gearing up to celebrate the 75th year of women being integrated into our armed forces. As a result, there are states all over the country that are gearing up to celebrate our mark on history. As we reflect on the current landscape, we recognize the evolving nature of the women veteran community. We are the fastest growing population in the veteran set. We are surpassing boundaries and we're breaking stereotypes every single day. Furthermore, the demographics of women veterans paint a picture of diversity and intersectionality. With a median age of 50, these women continue contributing their unique experiences and their perspectives to our society. As we go deeper into this topic of end-of-life care for women veterans, I want us to carry this understanding with us. I want us to be able to continue to recognize the diversity and the unique needs of this population as we strive to provide them with the care, support, and respect that they so deserve. As an end-of-life doula, I have the opportunity to journey with my fellow veterans through their end of life, and it's such an honor of a lifetime. I currently am journeying with a fellow woman veteran who allows me this space to craft and to help share and shape her story. Every week, similar to the book, if you all recall, Tuesdays with Maury, we have Tuesdays that we share a bit of her story. This woman veteran, and I will say her name because she too likes for me to say her name is Kim. And Kim was diagnosed with a glioblastoma last January. And it has been an honor of a lifetime to journey with her, collecting her story, having her story be a piece of an educational tool that we can impart to those that continue to care for our nation's heroes. Next slide. So here's the meat and potatoes. A little over a year ago, I embarked on a journey looking for scholarly literature related to the end-of-life experiences of women veterans. And as I searched, I came across one article that kept on popping up. And that article was entitled, Women Veterans' Use of Hospice and Palliative Care. And as I read the article, I was in awe. I was in awe that as a society, there was a significant gap in understanding the end-of-life experiences of women veterans. I carried that article with me, y'all. I live in Georgia, so I'm going to call everyone y'all. Please forgive me. I carried that article everywhere with me. Every opportunity that I had to speak about this topic, I did, as often as possible. Here's what I know for sure. Research empowers us to recognize the barriers that women veterans face. Research helps us to illuminate the gaps in our knowledge and forges a path towards providing the compassionate care that women veterans deserve. By immersing ourselves in their narratives, by actively seeking to understand their perspectives, we're able to embark on a profound journey of connection and empathy. Through this understanding, we are truly able to meet the needs of women veterans and ensure their final chapter is one of dignity, comfort, and peace. With that being said, I would love to turn the virtual stage over to my colleague and my friend, Dr. Brandon Verlick, one of the authors of the article that I just shared that's on your screen now, Women Veterans' Use of Hospice and Palliative Care. Brandon, is yours.
Thank you, Quinn, for the introduction. Like Quinn said, please don't call me doctor. I am Brandon to all of you. And what an honor it is to be invited to share this space with you all and to share my research experience and what I have learned over the last several years in my work with the female veteran population. I do want to apologize up front. I do have, as you can hear, my voice is not what it should be. So I have the microphone very close. If you do have trouble hearing me though, please make it known in the chat and I can try to adjust if you do have trouble understanding me. So I'm an assistant professor of nursing at South Dakota State University, and I work and live out of Sioux Falls, South Dakota. And I want to start by thanking all of the veterans of the United States Armed Forces for your service to our great country. I sincerely appreciate your service and the sacrifices that you made physically, mentally, emotionally, and spiritually to serve. As a nurse researcher, I am passionate about palliative and end-of-life research. On a national level, there has been significant progress towards improving palliative and end-of-life care. However, there is still significant work that needs to be done, especially in rural parts of the country and within certain populations, like with female veterans, like we're going to discuss. Another one of my big focuses is on health equity and health disparity research and how we can improve care for all people, not just majorities. Like Quinn said, there are over 2 million female veterans, which is a huge number. So yes, there are many veterans, and the 2 million of the larger proportion may be a small proportion, but it's 2 million individual people. That's 2 million unique perspectives, and it's 2 million stories that need to be heard and told. And that's 2 million people that we can't ignore. And that's same for all minority populations within the broader veteran community. So early within my tenure track at South Dakota State, or SDSU, the Department of Defense released a funding mechanism that aligned with my research interests with palliative care. However, you needed to have some initial data or pilot data to actually apply for that grant, which I did not have. I was fresh out of my PhD. I had no data to support what I wanted to do. So I started searching for what was known or what literature was out there for female veterans and palliative care, and couldn't find anything. So we pivoted into doing a scoping review to see what, and a scoping review is a very broad type of literature review where you cast a wide net to learn something more about what is known about a particular question. Go ahead and go to the next slide. So what we were asking our question about is essentially what was known about women veteran use of palliative and hospice care. And I did this study with a colleague of mine, Mary Isaacson at SDSU. And we searched the literature high and low to find anything specific to female veterans, and we just could not find it. So we had to do the best that we could. We followed a strict procedure of reviewing the literature, and ultimately we were able to get our findings published in Military Medicine. But what was it that we found? I want to highlight the findings of the scoping review on the next slide. We found 3 main things in the quantitative review of the articles, and we found 3 main things in the qualitative analysis. So the quantitative analysis of this review is just looking at like the structure of the articles that we reviewed. Hold on one second. For this review, we had 19 articles that we reviewed. Of the 19 articles, only 1 study consisted of all female participants. 3 articles had samples that only had male participants, and the other 15 studies were overwhelmingly male, consisting of 85 to 99% male. The second thing is that they failed to capture the diversity that's present with the US veterans, and especially within the female veteran population. 2 articles did not address race and ethnicity at all. 3 articles reported all white participants, which is not helpful. 2 identified white and other ethnicities were not reported. And 10 articles included Black and or Hispanic within the demographics, but did not further break down the other minority groups like American Indian or Asian Pacific Islander, things like that, groups like that. Additionally, there is an overwhelming amount of retrospective studies or studies that look into the past, back in time. So what these studies were doing was looking back into patients' charts of veterans who had already passed away. So any new information that they were gathering from these charts were actually coming from that veteran's family or from the caregivers to get the perspectives of the family caregiver about the phenomenon they were looking at. So they couldn't get any real significant data from the veteran themselves, other than from what was presented in the chart. Only 4 studies in the analysis reviewed things on a prospective basis, so actually sought new information from veterans themselves, 4 out of the 19. So we also looked at these articles on a thematic structure. So reviewing them and what kind of general things did we learn about the state of how veterans use palliative and end-of-life care. And there were 3 main things that we saw. These things were the quality of end-of-life care, distress, and palliative care consults. Quality of end-of-life care was generally perceived as positive, especially within VA facilities. But it was notable that the quality was perceived as higher if care was received within a community living center. However, minority veteran families reported lower quality of life at end of life than whites, and the chart review confirmed this finding, with Black veterans being less likely to receive palliative care or chaplain consults than whites, which is a troubling finding. Distress is another theme. This is important for healthcare providers to remember that how we approach veterans, and I know that everyone on this webinar is aware of this, but it's really important for me as a palliative and end-of-life researcher to share with the broader palliative care community that veterans' experiences at end of life are very different from the general population because of the unique military experience that causes moral injury and causes very unique distress at end of life. And you need to approach the end of life experience in a different way. Lastly, there's a palliative care consult itself. And we found that for veterans who lived in rural areas, did not find that palliative care yielded improvements in their quality of life, which is strange because generally palliative care, you see great improvements in quality of life. So that's a sign that palliative care delivery is not adequate in a rural setting, especially for veterans. So that's another area that needs a special focus. So what is next after these findings? So the biggest thing, especially based on the quantitative look at these articles, is that we need to do prospective and purposeful research with female veterans. We have 2 million female veterans. We need to do research with female veterans specific to palliative end-of-life care. So what I did is I took this data from this scoping review and applied for an internal grant within SDSU to assess palliative care knowledge and to assess symptom burden of those living with serious illness. We can go to the next slide. So I was able to secure an internal grant through SDSU to do just that. It was a mixed method study. And for this specific study, I introduced a comparison component for female veterans who received care primarily at VA medical centers or civilian facilities. So that was one of the questions I asked them, whether they received care primarily at VA MCs or at civilian facilities. Collected data in 2 ways for this particular study, online surveys, or a couple of online surveys, and then I also did interviews with a smaller cohort of the same people who did surveys to hear those veterans' experiences of living with their illnesses. Next slide. So for this study, I recruited on Facebook I recruited using a Facebook and Instagram ad. And like Quinn was one of the people who found this ad, and Rael and Salzano also found this ad on Facebook and helped get me connected with some female veteran groups on Facebook to spread the word about this research and were instrumental in the success of the recruiting for this study. So I had 179 female veterans partially complete the surveys online. 152 fully completed the surveys and were included in the analysis. At the end of the survey, participants were asked if they wanted to do a follow-up interview. 19 people said yes, and 10 people ended up completing the interview. Survey participants could opt into a drawing for one of 4 $100 Amazon gift cards. Additionally, any interview participant was eligible to receive an additional $25 gift card. So we had 10 interviews. 2 of the 10 interviewees declined to receive a gift card in favor of supporting other female veterans who were needing the money more than they did. SDSU IRB did approve this study as an exempt study, and this work has been completed and is under review in the form of 2 manuscripts. And I want to provide the audience today and for the recording an early look at what what the results look like for both of these manuscripts. So the first one that I want to describe is a look at the interviews or the discussions that I had with female veterans and how they described their personal intimate experiences of living with their serious illnesses. Next slide. So this slide is a bit wordy. I apologize. But within our interviews that we had or that we did with these female veterans, we had 3 main themes that came out of the interviews. And 2 of the themes, the first and the third themes, you'll see are partially or fully in quotes. Those themes came directly from the participant narrative. So you call this quality of life. That theme name came directly from one of the participants. Coming to terms, and then the third theme, it changes everything. So I've included some quotes directly from participants on the slide to give a sense of what they're experiencing in their lives. I want to give you a little bit of background on each one of these themes and then read to you what the female veterans are experiencing. So under you call this quality of life, how we kind of frame this theme. A lot of the female veterans said or shared that I've become a loner or I've become more and more reclusive. These are very common statements among our participants. The participants vividly described the havoc that their chronic illnesses have on their quality of life. One of our participants suffered from psoriatic arthritis, which can cause highly visible plaques and lesions on the skin. She shared how she used to enjoy being able to go visit with friends, but because of her disease, she feels shunned. So on the quote on the slide, she says, I've become a loner, whereas I was more of an outgoing person and it's been lonesome, my quality of life. I mean, otherwise I'm healthy. I mean, as far as blood pressure and cholesterol and all that internal stuff, I'm fairly healthy. But outwardly, that's what people look at. When they walk through the front door, they don't ask, how's your blood pressure today? They see stuff on you, and it's not very good being shunned. Coming to terms is the next theme. Participants expressed a mindset of coming to terms with their chronic diseases. Each one shared how full and productive their lives were prior to disease onset and how the disease has negatively impacted their lives. One participant shared this: I'm either going to have to take it back or it's going to take me out. Determination is one of my strong suits. I'm either going to have to get it, the function back, or I'm going to die. And that's a really bad balance to have. The last theme is it dictates everything. Living with a chronic disease created feelings of powerlessness among the majority of participants. Powerlessness manifests in many ways for the participants. When the disease becomes visible, when they needed to change healthcare providers, when their physical symptoms worsen, or the constant fear of living with the unknown. One participant shared the powerlessness she experienced with her disease when simply shopping. When we went to purchase new cars, I had to sit in the car to see, okay, does it touch my hips? Yep, so I can't even sit in them. So I see that it dictates everything. We needed to buy a new couch and chair. I had to sit in them for a while to see how it would do with my hips. I can sit in them and tell you definitely when it's a no. However, there were some, let me sit in it for a while. I mean, it just takes you twice as long to do everything that a normal person does. So you can see that each, and I have many more examples from the article that support each one of these themes, but these female veterans talk about their diseases in very personal ways and how they have to, and how their quality of life has suffered because of their diseases. And I think the thing that was interesting with the findings with this is that I did not limit the inclusion of to participate in my study to service-related chronic diseases or service-related diagnoses or things that they got that would make them benefits. They had to be benefits eligible through the VA, but their serious illness did not have to qualify them for the benefits through the VA. So a lot of these veterans are suffering with serious illnesses that were not a direct result of their service, but they're still suffering. So how do we help them? Next slide. For the next piece of this grant, we did the surveys online. And I want to share the palliative care knowledge and the symptom burden data that we found. So this article is also under review. For the broader demographics of this, I have a couple of the demographics that are of note. So of the 152 participants, 104 got their care primarily from VA medical centers. 48 received care primarily at civilian facilities. A majority of the sample were white, 86%. So unfortunately, we did not capture the vast demographic, all the minority breakdown of the female veteran population either, but I think we have ways to correct that in the future. 63% were married or in a domestic partnership. Household income for most, about 68% was between or below 50,000 or between 50 and 100,000. 48 or 31% reported at least one chronic disease, and then 42.8% reported two or more chronic diseases. So fairly significant risk for symptom burden among these participants. Next slide. So the first piece of this is that we measured palliative care knowledge. And one thing I want to preface here is I think everybody here is probably aware of the differences between palliative and hospice care, which is why I'm not explaining that. That's not the purpose of this. But I did not give any context to the participants in the study. I simply just gave them the instruments to see where they were at. And I measured palliative care knowledge in two ways. One was a perceived knowledge of palliative care. So I asked them how familiar they were and what their perceived knowledge was. So on that self-rated knowledge, the veteran population rated themselves at 3.2 out of 5. And that was actually pretty close with the results that we found in the actual palliative care knowledge scale at 8.66 out of 13. So those are, and actually they may have underreported what their actual knowledge of palliative care was. So back to the top here, 52.6 of the sample, so well over half of our sample had heard of palliative care but had not been offered palliative care. And only 7%, or only less than 5% of our sample actively receives palliative care. That is not a lot, considering 43% of the sample have 2 or more serious illnesses that would qualify them for palliative care. So there are some serious gaps in palliative care, either availability for the population, or the providers are not referring them. There's something in the way of getting this population across the line or across the threshold from, you have these serious illnesses, let's get you into palliative care to improve quality of life. So there's something in the way there. So I was trying to explain a little bit of why women veterans have such a high level of palliative care knowledge, because in initial community testing of the palliative care knowledge scale, like general community dwelling lay persons is what they refer to them as. So just a typical community sample, their scores are like 3 out of 13. So the women veteran population did phenomenally well in comparison. But I thought it was interesting that the National Alliance for Caregiving in 2020 found that 61% of all caregivers were female and were caring for adults over 50. Additionally, they found that African American, so Black and white caregivers are more likely to be veterans, which is where a lot of the veteran demographic breakdown lies. And so I think that's potentially why we may have a higher proportion of our sample that is more familiar with palliative care, because we may have a higher proportion of our sample who have served as a formal caregiver in the past. So I think going forward, that's something that we need to be asking, so that we can better target our knowledge generation is, have you served as a caregiver in the past? Because if they have, great, then we can arm them with the tools that they need to advocate for themselves. Because I'm sure that we all unfortunately know that the healthcare providers don't always advocate on our behalfs for us. So, and I say that as a healthcare provider. So anyway, soapbox, I'll get off of it. Let's go to the next slide and talk about symptom burden. So for symptom burden, we measured physical symptoms, psychological symptoms, and then total burden. So we have a couple of key things that I want to highlight about symptom burden. For our sample, may not be true for the general population, but for the 152 women veterans in our sample, older veterans were more likely to report lower total burden scores compared to younger veterans. So the younger veterans had a higher total burden or total symptom burden than the older veterans did. Disabled veterans had higher total symptom burden compared to non-disabled and those able to work full or part-time. And those with 2 or more chronic diseases reported higher total symptom burden and physical symptom burden than those with only 1 or no chronic diseases, which is not surprising. The more chronic diseases you have, the more symptoms you're going to have of those diseases. So that is not a surprising finding. The other 2 were more surprising to me. But when you, so that's another thing that I need to consider as I go forward in my next steps with research, is finding which era they serve. Because for my younger veterans, I had my young group too broad. I think it was 18 to 45 or 18 to 40. I can't remember off the top of my head. And it was too broad of a grouping to see when they potentially served. So that was a shortcoming on my end, to see when they served, see what potentially was causing that. So another interesting finding in our results was so the breakdown between the VA and the civilian facilities found that people who seek care at VAs or VA facilities in our sample had higher symptom burden than those who seeking care at civilian facilities. But we found that people seeking care at VAs In our sample, those are the people who had multiple serious illnesses, more so than people at civilian facilities. So if somebody was receiving care at a civilian facility, they were much more likely to have multiple serious illnesses. So, next slide. So where do we go from here? It's pretty clear from my very preliminary research that we're really just scratching the surface of understanding the female veteran experience of living with serious illness, especially as they approach end of life in terms of the scientific literature. And I know that Quinn is doing excellent work, and there are so many groups doing phenomenal work with women veterans, but it's not represented in the scientific literature. So what do we do next? And I have a couple of ideas. And if anybody has a lot of money out there, I'm talking to you. We need funding mechanisms that can support developing innovative approaches to deliver palliative care to female veterans. The VA has done wonderful work with palliative care and hospice care over the last 20 to 25 years. And in many cases are doing much better work than civilian facilities are doing at palliative care. But there are still significant gaps in how palliative care is available for people who are outside of the inpatient or who are not inpatient, how it's available in the community, how it's available in rural settings, how it's available at satellite clinics. So there's a lot of work that needs to be done to increase the availability of palliative care to those who are living in rural and frontier areas. And living in South Dakota, we have a lot of our veteran population living in the western side of South Dakota, which is highly rural and frontier. There's not a lot out there. So how do we deliver palliative and hospice care to them when it is their time or when they need it most? And unfortunately, I don't have a good answer for that right now. Next slide. So one of my ideas is to use the tools and the experts that we have at our disposal. So what do I mean by that? I mean that we need to take advantage of the most populous healthcare professional that we have, and those are nurses. Nurses are well equipped to deliver many of the components of palliative care, especially at the primary level. So in my research, I'm working on developing interventions that deliver nurse-driven palliative care to rural persons who live with cancer. I don't see a reason why this approach can't be taken with veterans as well, who live in rural settings. Physicians and advanced care providers are difficult to pull away from clinical responsibilities, but nurses are more able to incorporate these concepts into their everyday care. And they have more trust with their patients. They're with them, they are by their side all the time. And if researchers can build these nurse-driven interventions to target the female veteran population, I think we can start to turn the tide a little bit and get female veterans more engaged in palliative care research, or more engaged with palliative care, get it introduced sooner, and help improve quality of life and help see some better outcomes for this population. So with that, I would like to turn it back over to Quinn before we open up the conversation for discussion.
Thanks, Brandon. Thank you for sharing where we are in the state of affairs for research, right? And I think for so many, me included, sometimes when we hear about research and what's happening and what are the implications, it's daunting, and it seems like, where do we go from here with the time that we have? So I'm so glad that you had the opportunity, Brandon, to share where we are in 2023 and having the audience realize that there is so much work that still needs to be done. But the other side of me, as not the researcher, but as the conversationalist, I like to implore people with what if futures. What are some of the things that we can do now if we are extremely intentional? So as we envision the future of end-of-life care for women veterans, let's try to explore the transformative potential of public awareness, outreach engagements, and partnerships and coalitions. I think this is a great platform right here within We Honor Veterans to do just that, to lift up the experiences and the perspectives of our women veterans. So thinking about public awareness, how do we shine a light on the needs of our women veterans through the end of life? How can we imagine a future where their needs and experiences are widely understood and acknowledged through robust public awareness initiatives? We can illuminate their unique challenges, amplify their voices, and foster a society that values and supports their journey. So here's just a few practical ways on how we can get moving today. Messaging, the way you message with your materials truly matter. Ensure that you're using cultural and gender sensitive language with all that you do as you're supporting your veterans in the organizations in which you serve. Your visuals matter. So if you take a look at your websites and you're looking at the services that you provide for veterans, are they reflective? Are they diverse? If I was to look on your organization's website, would I see a woman veteran and be able to connect and say, okay, wow, this hospice or this palliative care provider provides services for women like me? Are you asking the question, right? Engaging your communities to begin asking the question, not the question, are you a veteran? But more so the question, have you served? Because when we think about women veterans, as I stated earlier, we're only 75 years in integrating them into our armed forces. That's really not that long. So you're going to want to ask that specific question, have you served versus are you a veteran? Because some women veterans are not going to identify just as yet at being called a veteran. I will be completely honest with you and share, when I came home from active duty, it took me years to identify and share that I was a veteran. I did not deploy. I mobilized, but I did not deploy. And at that time in the early 2000s, what I envisioned, and I'm dating myself, as an early 20-something-year-old, I didn't see myself as a veteran. So it took a really long time for me to identify, but it's also important to take into consideration that veterans that are facing serious and life-limiting illnesses are not just the aging women veterans. You have women veterans, as I shared, Kate, who was 41 or 42 when she died. So you're seeing younger and younger veterans that are having serious and life-limiting illnesses. Some of them are related to toxic exposures while they were deployed in combat zones. So let's really be intentional with asking questions. Have quarterly webinars. Invite local and national subject matter experts into these conversations where they can share with your community topics related to women veterans specific issues. That may be military sexual trauma, that may be moral injury and how moral injury impacts women veterans. It might be post-traumatic stress, can go on and on. We can talk about health issues, gerontology. So really take the time to figure out where your experts are. I can guarantee you, you have some right in the state and in the communities in which you serve. Offer your staff and your care teams professional development, whether it's trauma-sensitive communication they're learning about, whether it's more awareness as it relates to veterans as a whole, trauma-informed care, whatever you can do to allow your care teams to see more than just the male veteran when they close their eyes would be super impactful. Thinking about outreach and engagement. Almost everyone that is sitting on this call today is somewhere between a level 1, a level 5, stellar organizations that are supportive of We Honor Veterans. Reach out to every corner of your community to ensure that no woman veteran, one, faces their end of life alone or faces the end of their life still, and I'm going to say it again, still feeling invisible. By developing and implementing proactive outreach initiatives, we can establish connections, provide resources, and create a network of support that extends every corner of the military and veteran community. Outreach to women veterans in your geographic area. Observe Women Veterans Day, which is June 12th, 2023. If you all have an event planned, please drop that in the chat so that we're able to start having and generating ideas on how we can honor and celebrate women veterans, not just this June 12th, but every June 12th moving forward. Partner with your local libraries, partner with your senior centers, partner with your veteran service organizations like your American Legion, your VFW, your DAVs, where there are women veterans that are embedded, and conduct listening sessions and learning circles. Have women veterans have a seat at your table as you are beginning to develop projects and initiatives, not on them, but with them. It's important that we are constructing these initiatives and these projects, not just for women veterans, but including them in the work that you're doing, having their voice at the table. Finally, develop a cadre of women veteran volunteers in your communities that are able to conduct life reviews, oral history interviews, where they can take that oral history interview, have that collection sent up to the Library of Congress's Veteran History Project, and have that veterans collection housed forever. Partnerships and coalitions. I know that's what many of you all do, right? Imagine a future in your community where organizations, agencies, and individuals come together in a powerful partnership driven by a shared mission to enhance end-of-life care for women veterans and veterans as a whole. By joining forces, we are able to harness collective wisdom, resources, and expertise to really impact long-term and lasting change. So when you think about those partnerships, one organization I definitely want you all to look into, if you have not had the opportunity to see the work that comes out of the Center for Women Veterans, which is housed under the VA, please look at the amazing work that they're doing. Collaborate with your VA or your Women Veterans Program Manager. That's on the federal side of the house. But also in every state, you have your State Department of Veterans Services. There is a Woman Veterans Coordinator embedded in every state's Department of Veterans Services. Get to know who they are. Invite them to your, for example, if you're a level 5, invite them to an event so that they're able to provide training to your staff and to the community that you serve. So I ask all of you, and these are just a few simple things that you can start building today. What will you do? What will you change? And what will you take back to share with your teams? It's a lot, and we are in the space of continuing to learn what our various populations within our veteran community needs. You can take this model, you can take this framework and do the same thing with other minority veteran populations that you serve as well. But I truly ask you, what will you do in support of women veterans this June 12th? How will you be intentional with showing your level of awareness and your intentional efforts to provide them the comfort and the dignity and peace that they deserve through the end of life? Next slide. Now, I know that everyone can read, and I am of sound mind that it's very rarely okay to read a slide, but I feel I feel very strongly to read this slide, and I hope you all will just take a moment and close your eyes as I read this slide. We are not invisible. Let the generations know that women in uniform also guaranteed their freedom, that our resolve was just as great as the brave men who stood among us. And with victory, our hearts were just as full and beat just as fast, that the tears fell just as hard for those we left behind. This beautiful piece was written by a World War II Army nurse. Next slide. So for those of you all who have utilized the Psych Armor Institute training, 15 things veterans want you to know. I know that for volunteers in various hospice organizations that I have had the opportunity to work with, they shared that that's a part of their yearly training. Well, here's a bit of information. This fall, I've had the great opportunity to partner with Psych Armor, and we have created a new track, a new program specifically for caring for veterans through the end of life. So I would ask you all to please stay out on the lookout. I am sure that Catherine and Emily, as soon as it's launched, I will share that information with them so they can share it with you all. But just to give you a quick insight or a quick glimpse into what this new training will look like that is different from the 15 things, besides the fact that it's for the end of life journey, it'll be 3 courses. The first course will be focused on everyone, so communities at large. The second course will be focused strictly on caregivers and their loved ones. And the third course will be for you all, healthcare providers. So please stay out on the lookout for this upcoming training. The first one should launch September, October timeframe. And once again, we will get this information out as soon as it hits the waves. Next slide. And here are a few references from today that we talked about. Please feel free to share it. I know that Dr. Brandon's scholarly article, there is a link on the new webpage that will be shared in a minute. So you'll have information to his work. Here's some information that the VA has put out, and also an article that was shared in 2020 related to the narratives of women veterans. It has truly been an honor to be with you all today and to share this work and to share this space. Emily, I am going to turn it back over to you. I know we only have like 5 minutes for questions, but please feel free to drop them in the chat, whatever questions we cannot get to. Emily will send it to Brandon and I, and we will get those questions answered. But I cannot thank you all enough. Brandon, thank you for joining me, my friend. Thank you to Team We Honor Veterans for putting this together and to really shed a spotlight on conversations that matter as it relates to women veterans.
Thank you both so very much. It's greatly appreciated to have your expertise here with us today and to share it with all our partners who attended and who are watching the recording in the future. We do have some really great questions in the chat box, and I would also like to turn over to Catherine if she sees any other additional questions that I miss. So one of the questions is for Dr. Varlick regarding your comment on rural areas in the community. This question is, do you think it's regarding your comments on veterans and palliative care in rural areas, do you think it's because of a lack of community resources and not the quality of palliative care? The person who asked this question is from Central Oregon, and they do see a significant difference between the veterans we serve who live on the outskirts in very rural areas and those that live in a town. They have also seen many refuse additional resources or support, but it is also much harder to get those resources out to them.
Absolutely. I think that's one of the most significant challenges with how we deliver any kind of healthcare service in a rural setting is how you get the really high level tertiary type care that we can deliver in an urban setting, or that we can deliver in a large urban center, and how do we get that out into the rural setting, or into people's place of residence, essentially, without them having to travel to the main center. So we face that a lot in South Dakota too, where we have excellent care in many of the big cities in South Dakota, but we just don't have a way to deliver care in the rural small towns. So that's why we're trying to work on develop interventions that we can have a lower level of palliative care, or a primary level of palliative care delivery, so that they're getting some benefits of palliative care without having to introduce an entire interdisciplinary team, if that makes sense. So kind of the approach that we're thinking of is, how do we get, so something is better than nothing. And that's kind of what the approach we're trying to take. And that nurse-driven approach has been really successful in the South, like in Alabama. Project Enable is what we're adapting here in South Dakota. It's a very widely used intervention for palliative care in Alabama and in the Northeast. So I agree with you. It's probably not an availability or it's not a quality issue. It's an access issue.
Thank you so much for that. I know there's also a Women Veterans event happening June 11th that was shared in Oregon. So if anyone's in Oregon, definitely go ahead and check that information that Maureen shared in the chat box. One more question. This is for Dr. Galloway Salazar. As a woman veteran yourself, what are you most looking forward to in the future regarding like the psych armor presentations for women's at the end of life? And I'm not sure if you're familiar with the LNEC trainings. There are quite a few questions in the chat box, if it's similar, if there's like credit, and train the trainer type things.
Yeah, well, these are great questions and great things to think about as we are going deeper into how we're going to connect and collaborate with other organizations like LNEC to get the word out. So here's what's great. So I think there are about 3, I have an ambassador team that has stepped in to review all of this content, right? And I think 3 of them are a part of the consortium. And so it's great to have them embedded as an ambassador, so that when all of these 3 courses are rolled out, they have a connection to LNEC where they can share this as a resource to that community as well. This is completely separate from the offerings that they have. I know that they also have a specific course pertaining to veterans. This one really starts conversations, right? So often I hear in communities, we don't know how to start these conversations. Oftentimes, simply as lay people, simply as caregivers and loved ones, we don't know how to have these hard conversations that we know that we need to have. So these courses are more so geared for having these conversations and tips on what to do as we're supporting veterans, their caregivers, and their loved ones. So definitely our LNEC members will get it out to the consortium to put it out there if they so choose, to share the word and to share what this work is like. But when you ask me, what do I see in the future? I see these being ripple effects where conversations are being held and compassionate communities are being designed all over the nation to step up and stand in the space of supporting our nation's heroes and sheroes. Oftentimes we hear people say, thank you for your service. Let's take it one step further. When I think about these courses, it's truly allowing everyone in every community to realize they have a role in this space. They can do something, whether it's practical to emotional to spiritual to just cutting grass. Everyone has a role in caring for our nation's veterans. So if there are things that come up to the top that you would like to share that we can also add to this conversation, I am more than willing to collaborate and hear about some of these things. I know one state wants to take one of the films and have a panel discussion around it. They're a state agency for veteran services, and they want to explore having different panelists talk about their roles in end of life as it relates to veterans. So let's be creative, let's be innovative on how we're having these conversations with our communities.
Wonderful. Thank you so much. Catherine, do you have any further questions in the chat box?
Not necessarily from the chat box. I was just going to ask Maureen if you could please send the full info event so we can get that up on our events page in case there's anyone else who would like to attend. They can find that on our calendar. I did quickly, sorry, I know we're over time, want to mention, I'm so happy that LNEC was brought up. It just so happens that at the end of next week, the latest LNEC, and just in case for those of you who aren't aware, excuse me, LNEC is the End of Life Nursing Education Consortium done with the City of Hope in partnership with the American Association of College of Nurses. We have updated the curriculum. It will be on our website where the previous LNEC modules lived. Again, free and open to anyone to access. We will have some announcements going out to partners next week, press and marketing as well. But yes, know that those will be up on the We Honor Veterans website, the updated curriculum next Friday.
Thank you so much. And I'll just drop that link in the chat box as well. And I don't want to take too much of everyone's time. I just want to say thank you to all those who attended today, those who will be sharing this webinar with their colleagues. And thank you so much to our presenters for sharing their knowledge. It truly does mean a lot to everyone here. Thank you again. And I hope you all have a wonderful rest of your day. Have a great one.
Thanks, everyone.